Hello, my name is Kelsey Peterson. I am a registered dietitian with Center for Discovery. I have been with the company for, I'd say, almost 4 years. I started as a diet technician, so I was kind of doing a lot of the meal preparation and kind of worked my way up in the company. And when I became a dietitian, I was hired here at the La Jolla location in San Diego. I had my internship at Cal State Long Beach that was paired with a master's in nutritional science. So it's a great program for whoever is interested in pursuing dietetics. I definitely recommend it. And I've been working with eating disorders for about 4 years. Kind of fell in love with the field. I'm currently working towards my certification in becoming an eating disorder registered dietitian, and we'll be finishing that up in March, April. So I'm definitely very excited to be speaking with you all. Sorry I'm on video, but if you have any questions, I'm sure I can provide my contact information. I would love to receive any emails if anyone has any questions. So I've been asked just to go through the initial dietary assessment in terms of when we get new clients in, kind of what we're screening for in terms of the dietary component and what is appropriate. I apologize, I'm a little stuffy, I'm getting over a cold, so hopefully everyone can understand me. So at this level of care, we are a residential treatment center. So our comprehensive assessment is pretty detailed, and we're looking for very specific things. Our clients are definitely very high risk, very sick, so we are definitely screening for a lot of health issues, as well as trying to create the most appropriate meal plan, weight restoration, or stabilization plan for them. So I'm gonna walk you through it. The first thing we kind of assess is where they're at in terms of their weight and height. I do calculate their ideal body weight, which is based on, usually I get their growth charts, and it's their 50th percentile of where they should be for their age and height. I do like to get their growth charts and see where they've kind of been at throughout their childhood, their adolescent years. So whether that's always been consistently the 25th percentile, the 75th percentile, I kind of like to keep it on that track, that line, but as a rule of thumb, our goal is always around 50th percent. So whether a client is underweight or overweight, I will put them on, if they're underweight, a weight restoration plan. If they are overweight or at weight, our goal always in the residential treatment center is to provide stabilization. We are never going to recommend or promote any type of weight loss program. Our goal is always stabilization. If their body naturally and healthfully loses weight at a very slow rate, if they are overweight, that's okay, but that is never our goal when working with eating disorders. I do assess what their lowest body weight is and what their highest body weight has been. Once again, this will give me a better understanding of where they've naturally been in terms of the weight for the majority of their life. I do like to also ask them what their personal goal body weight is, because it will kind of give me an idea of how entrenched they are into their eating disorder, because if they've always been 130 pounds and if they say, well, my goal is 60 pounds, I kind of have a very good understanding that the eating disorder has very much warped their perspective of their bodies and what is considered to be an appropriate weight. I do ask them about if they're on any birth control hormonal methods of contraceptives. Once again, the loss of a period is a very good indicator of malnutrition. So if a client comes in saying, they've lost their period, it's very easy. It'll be a very easy, concrete thing for me to say, okay, that's a very great clue that your body is malnourished, underweight. However, if we have a client coming in on birth control and they've always had regular periods because of that, it gives us a kind of a false indicator of health, that the client will be like, oh yeah, I'm fine, I've had my period very consistently. But if they're on a birth control that's helping them do that, it will definitely warp that perspective. So ideally, we kind of like to get them off birth control to see where their body's at naturally. I do ask them if they're taking any vitamin, dietary supplements. Sometimes I have clients coming in with nothing. Sometimes I have clients coming in with a whole list of dietary supplements. Sometimes clients will say, I'm totally healthy, I don't eat anything, but I take my multivitamin, my calcium, my fish oil. So once again, providing a lot of education on what's an appropriate nutrition supplement and what's not appropriate. At the residential level of care, we always do recommend a multivitamin and a calcium, since bone loss and osteopenia, osteoporosis is so common in the eating disorder realm. So we always want to make sure that they're getting enough calcium. I always make sure to ask them if they've ever worked with a dietitian before or a nutrition professional, and make sure I am contacting that professional within 48 hours to make sure the continuity of care is there and to make sure I have a better understanding of this client's history and their background. I do screen for their medical history, other chronic medical conditions. Once again, osteoporosis, that's bone loss, very common in eating disorders, a very clear indicator of malnutrition. That's a case putting them on a high calcium diet, making sure they're eating enough calcium-rich foods, vitamin D, as well as like diabetes. Once again, anything that might require a very specialized meal plan that is appropriate. Ask them about what their food allergies and or intolerances are. I do have to be careful because eating disorders love to say that they're sensitive to this and sensitive to that. It's a very easy way to restrict food by covering it up with a medical issue. I do require that all claimed allergies or food intolerances, they have to be approved by a doctor and actually have medical proof obtained to make sure that it is legitimate. Some of the most common things we see in the residential setting is lactose intolerance, random allergies, pineapple, nuts, so making sure that those are all medically approved. I do screen for religious beliefs that will affect eating habits. Once again, I have to be careful because the eating disorder can say that this person, for their religion, doesn't eat this type of thing. So it doesn't have to be a very legitimate religion, and food preferences. Once again, some common ones in this setting is like kosher. So we will do everything possible to honor those religious preferences, but it does have to be legitimate. I do let my clients have 3 genuine food dislikes. However, they have to look and sound appropriate. If a client says they don't like pickles, I'm like, no problem. If a client says I don't like any type of sweet, which is very common for eating disorders, then I will not approve it, but I will say we can kind of hold off on, not requiring you to eat these items, but we're going to explore it in sessions and kind of see if this is a genuine dislike or if the eating disorder has kind of really, once again, warped their perspective around this type of food. I do ask if they're vegetarian and or have ever been vegan. Once again, I have clients coming in saying they're vegetarian, vegan, their raw food diet. The eating disorder really loves to hide behind all these labels and fad diets. We do allow vegetarian diets in the residential setting. Other than that, that's basically it. And once again, that vegetarian diet has to be approved by the parent if the child is under 18. So it does have to be confirmed by the parent. I will usually always explore that though with them further and really challenge them on the vegetarian component and to see if that is authentic or if it, once again, is the eating disorder kind of hiding behind that label. I do assess family medical history, seeing if there's any eating disorders that are present in the family that can definitely affect the child and their eating disorder history. So it's important to get that information. I'll screen for physical symptoms of the eating disorder, hair loss, abnormal hair body growth. I'll definitely check in with GI issues, diarrhea, constipation, all very, very common and do require dietary intervention. So it's important for me to know this as well so I can make appropriate recommendations and kind of tailor their meal plan to help heal those symptoms. I will screen for compulsive exercise, so I ask them about their relationship with exercise and what their background is with that. I'll also ask them if they feel they have disordered eating. This is kind of a mixed bag. Some clients are like, yep. Other clients are kind of in complete denial. So I do know, it gives me a good understanding of where the client's at in terms of that motivation for change. And if a client's saying like, no, I'm totally fine, and yet they're eating 100 calories a day, it'll give me a very clear understanding of how much work we have to do and to help them realize how sick they are. I do kind of have them give me a picture of when their eating disorder started, so how old they were, what behavior started happening, to kind of walk me through that process of how the disordered eating progressed. I do like to also get this information because typically the age in which the behaviors start, so if a client starts displaying disordered eating behaviors at 9 years old and is now 16, mentally, that child will stay mentally a 9-year-old because the malnutrition can happen so quickly. So a lot of times we get these clients who are 16 years old but act like a 9-year-old because of that very thing, is that they are very malnourished, and the age in which the eating disorder starts is typically mentally the age in which that client stays. Sorry. I will assess for any current restrictive behaviors, so food restriction, seeing how severe that is. Sometimes clients are very, they give me exact numbers, like I only eat 200 calories a day, or I only eat 1 apple 3 times a day. So some clients are very specific, some clients are just like, I have a snack. So kind of assessing that. I will assess current binging behaviors, how often they're binging, is it in secret, what kind of foods they typically binge on. Usually their typical binging foods are foods that they restrict, so sweets, fast food. Once again, this psychological component that the foods we restrict are typically the foods that we also binge on. I will assess purging behaviors. Purging is actually one of the most dangerous type of eating disorder behaviors because when we purge, it does shift our electrolytes in our body. Our electrolyte in our body, the electrolyte levels are very specific and are responsible for maintaining our heartbeat. And so if those shift inappropriately, we do have a higher chance of having a heart attack. So purging does have a very high risk of mortality. So making sure that we screen for that and see what the significant of the purging behaviors are. I have clients coming in that can purge 20 times a day. So once again, definitely making sure that if a client comes in that does report purging, that the staff is notified so we can increase the monitoring 24-hour observations. I assess for laxative use. Once again, laxative use has a very serious impact on the GI system, in which once these clients are taken off the laxatives, the GI system essentially stops functioning because it's been able to have this pill, this medicine that has been able to do all the work for it. So the refeeding process is actually very difficult for these clients because they have to learn how to use their GI system all over again. So these clients have a higher risk of constipation, diarrhea, bloating, just overall discomfort. So making sure that if we have a client coming in with laxative use, that we are pretty sensitive to how painful this can be. So offering any other medications that aren't as severe as laxatives if needed. We do screen for diet pills, also caffeine intake. Caffeine can be a very common thing to drink in order to suppress appetite. So in the residential setting, our clients are not allowed to drink caffeine because it does mess up the hunger fullness signal so greatly. And this is something we're trying to help our clients get back in touch with. Okay, I do screen for eating disorder behaviors around food. So this is like cutting food into tiny pieces, ripping food. Hold on.